Saya benar di sini ya.
Ini berkumpul di technical room, Prof. Saya sudah berusaha memindahkan, Prof.
Prof, panjenengan jaringannya putus-putus itu, Prof.
Jelasin saya mendengar berarti jelas itu.
Nah, niki sampun.
Ya,
Prof, ini semuanya ada di breakout room. Panjenengan sudah mau dipindahkan tapi belum bisa pindah dari Mas Ari. Atau panjenengan mau masuk ke breakout dulu, Prof?
Ya,
dekat sendiri ya?
ya coba.
Di teknik dulu.
Ya,
Nggih,
technical room.
iya, nggih, semuanya ada di situ, Prof.
Berarti nanti seminarnya di room itu ya?
Bukan, nanti kalau sudah selesai breakout-nya ditutup. Kalau sudah siap breakout-nya ditutup, Prof. Nanti semuanya masuk main room.
Bentar. Ini technical room ya?
Nggih.
Prof aman. Prof,
Nah,
tolong nggak
sampun.
itu backgroundnya belum ganti itu loh. PM itu sudah sekian purnama nggak ganti back, masih terkenang background yang lama nih kayaknya. Wah. Padahal backgroundnya sudah saya japri bolak-balik loh ini.
Dokter mau dimulai sudah jam 13.02. Mau dimulai atau menunggu sinten malih?
Sudah datang semua dok, sudah hadir semua.
Oke, bisa dimulai Dokter Flora. Cek.
Bisa dok, bisa. Monggo silahkan MC. Go ahead, silakan.
Bentar,
Ladies.
tunggu sebentar.
Oke.
Tunggu sebentar. Technical breakout-nya mau ditutup Mas Ari itu.
Oke.
Oh, ya.
Kita tutup breakout, nggih, kita mulai. Terima kasih.
Terima kasih dokter Ate.
Oke, saya mulai ya Dokter Flora.
Nggih, monggo dokter.
Nggih, monggo.
Okay, Bismillahirrahmanirrahim. Ladies and gentlemen, now we will start the webinar. Honorable Vice Chancellor of Universitas Muhammadiyah Surakarta, Board Chairman Associations of Muhammadiyah Medical and Health Education, Professor Dr. M. Sutrisna M.Kes, Honorable Board Chairman, Japanese Medical Schools International Collaborative Assembly, Professor Yoshikatsu M.D. Ph.D., Honorable Vice Board Chairman, Japanese Medical School International Collaborative Assembly, Professor Yashiro M.Ph.D., Honorable Vice Board Chairman, Association of Muhammadiyah Medical and Health Education, Dr. Wawang Sukarya, Specialist Obstetric Gynecology Consultant, Honorable Vice Deans of Medical Faculty, Universitas Muhammadiyah Surakarta, Dr. Flora Ramona Sigit Prakoso M.Kes, SPKK. Distinguished moderator, all speakers, medical students, doctor, and lecturers from Japan and Indonesia. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and konnichiwa. We would like to thank everyone here for joining in this webinar. I'm Nining Lestari. On behalf of the organizing committee, I'd like to welcome all of you today in the International Webinar 2022. It will discuss about the current treatment for diabetes, what medical students and young doctors need to learn. This event is organized by Association of Muhammadiyah Medical and Health Education in collaboration with Japanese Medical School International Collaborative Assembly. This is our second collaboration after the first webinar that was held in April 2021. Okay, next. Let me inform you some rules to all participants. This event is recorded and broadcasted live through official FKWMS YouTube. Participants are automatically muted at the beginning of sessions. During the presentation, participants may write questions to the speaker in the chat box. Some of these questions will be taken up by the chair. And then during the Q&A and comprehensive discussion session, participants may share a question by raising their hand or writing the question and comment in the chat box. Participant will only be able to ask the question or provide comments upon invitation by the moderator. All material will be sent into the chat box. Please fulfill the attendance form at the end of these sessions to get an A certificate. Next. Okay, next on this special webinar, we have several agendas. So allow me to read several sequence agenda today. The first is opening, short remarks, and then the main session. There are 2 sessions of presentation with each Q&A session, and then followed by the comprehensive discussion. And the last is closing remarks. Okay, now we will go to the opening session. This opening session will be conducted by Professor Takashi Yashiro, M.D., Ph.D. But let me read the curriculum vitae of Professor Yashiro. Next. Prof. Takashi Yashiro graduated from Ottawa High School in 1971 and then got a medical doctor in 1978 and a Ph.D. in 1984. Since 1978, Prof. Yashiro active as speaker. Next. Prof. Yashiro, since 1978, active as a researcher, lecturer, at some universities in Japan. Recently, Prof. Yashiro has chaired as Professor Emeritus, GC Medical Universitas of Medicines, and then Honorable Professor of National Mongolian University of Medical Science, and then visiting Professor of UHAMKA, Universitas Muhammadiyah, Professor Dr. Hamka, Indonesia. And Prof. Yashiro received the Yoshimune Prize by Japan Society for Pituitary Research at 2010. He also member of Pituitary Research Associations of Anatomists, Endocrine Pathological Society, and Endocrinology Society in Japan. Okay, I will invite Prof. Yashiro to conduct the opening sessions. Please welcome Prof. Takashi Yashiro. Thank you.
Can you hear me?
Okay.
Okay, thank you very much for your very kind and concise explanation of my CV. I think a little too much. Anyway, I'm very happy to declare the start of the second international webinar. As you see, this webinar is collaborated by 2 associations. One is Japan International Collaborative Assembly and Association of Muhammadiyah's Medical and Health Education. And at first, I would like to thank especially the committee member of SURAKARTA University Medical Faculty. This webinar is operated by them. Special thanks to Dr. Flora. Thank you very much. Well, at this opening ceremony, I would like to ask 4 doctors to make the opening remarks. First, Professor Toshikazu Eto. He's the board chairman of Japanese Medical School International Collaborating Assembly. Professor Eto, please. Professor Eto, please.
Okay, thank you very much, Professor Yashiro. A kind introduction to me. And my name is Yoshikazu Eto, chairman of the Japanese Medical School International Collaborative Assembly. And on the behalf of this society, I would like to congratulate to organize the second international web seminar between Japan and Indonesia. This meeting is hosted by the Faculty of Medicine, University of Muhammadiyah, SURAKARTA, and several doctors, Dr. Novita Mahmuda, Department of Internal Medicine. And also we discuss about the current treatment for diabetes, what medical student and young doctors need to learn. This is so exciting since many human beings are involved in this world by diabetes. And so this is a mutual great topics. As a human being, we should discuss extensively to collaborate together. So thank you very much for organizing such a wonderful website meeting between Japan and Indonesia. And I hope this meeting will be successful for both of us. And thank you very much indeed for the organizing member, Prof. Yashiro, and also Dr. Bestar, and Dr. Lestari, and I'm sorry, other members of your society, and Dr. Luya, several other members. Thank you much for your great attention. Thank you.
Thank you very much, Professor Eto. Eto says, arigatou gozaimasu. Next, I would like to ask Professor M. Storiner. He is the board chairman of the APKKM. Professor, please.
Thank you very much, Professor Takashi Yashiro. Honorable Professor Yoshikatsu, Chairman of Japanese Medical School International. Honorable Professor Takashi Yashiro, Ph.D. Honorable Professor Eijiro Yamashiro, Vice Chairman, Japanese Medical School. Professor Wawang Sukarya, Dean of Universitas Muhammadiyah, Jakarta, Muhammadiyah UHAKPA, Jakarta. Honorable Dr. Iin Novita Nurhidayati, Indonesia. Honorable Professor Eijiro Yamada, the Honorable Speaker Yoshimune Hiratsuka, Associate Professor, Speaker. Professor Keiichiro Matoba, Speaker. And ladies and gentlemen, all participants, first, all pray to Allah Subhanahu wa Ta'ala, God, because His blessing we can have this agenda. This webinar is one of implementation of Memorandum of Understanding between Japanese Medical School International Cooperative with Association Muhammadiyah Medical and Health Education, APKKM. Ladies and gentlemen, Professor Yoshikatsu, and ladies and gentlemen, for information, Association of Muhammadiyah Medical and Health Education consists 12 medical faculty. Universitas Muhammadiyah Yogyakarta, Universitas Ahmad Dahlan Yogyakarta, Universitas Muhammadiyah Surakarta, Universitas Muhammadiyah Semarang, Universitas Muhammadiyah Surabaya, Universitas Muhammadiyah Malang, Universitas Muhammadiyah Makassar, UHAMKA Jakarta, Universitas Muhammadiyah Jakarta, Universitas Muhammadiyah Palembang, and Universitas Muhammadiyah Sumatera Utara. So we are powerful. I hope next time we can arrange the model of collaborative, not only webinar collaboration, but also maybe rich collaboration, student and staff exchange, and maybe matching funds. And in this agenda, I hope agenda running well, and God bless us. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor EM. Thanks a lot. Next, I would like to call Professor Yamashiro. He is a Vice Board Chairman of the Japanese Association. Professor Yamashiro, please. Not yet. Professor Yamashiro, please. Not possible to call him?
I'll try to look for the name, but I think the name is still in Japanese font, so it's some difficulties to read.
Okay.
Not in alphabet. I'm sorry.
Okay.
I cannot read.
I'll start from the beginning. Welcome to a webinar on current treatment for diabetes, particularly medical students and young doctors, because diabetes is a systemic disease affecting from the brain to the legs. 2021, the last year marked 100 years since discovery of insulin. Of course, you know that insulin is a mainstay for treatment of diabetes. Particularly, it is essential for the type 1 diabetes. There are two types of diabetes, type 1 and type 2. There are type 1 is disease resulting from the destruction of pancreatic beta cell, that autoimmune disease. While type 2 is due to insulin resistance based on obesity. So as type 1 mostly develop in childhood, the diagnosis and treatment are delayed, resulting in high mortality in such countries like low and middle income countries. So maybe Dr. Novita will explain about this, the situation in Indonesia. And also access to insulin, because it is quite expensive in people in such countries. So these are a big problem for the treatment of diabetes. Thank you very much indeed.
Thank you very much, Professor Yamashiro. Thank you so much. And next remarks will come from the Dr. Wang Surakaya. Dr. Wang, please.
Thank you, Professor Yashiro. Good afternoon, ladies and gentlemen. Good midday in Indonesia, I think. Honorable Professor Eto, as the chairman of the Japanese Medical School International Collaborative Assembly, Professor Yamashiro, past president of Japanese Japanese Association, Japanese Association, and then Professor M. Sutrisna as the chairman of Association of Muhammadiyah Medical and Health Education, Dr. Flora, the Dean of OMS, my best friend, my best friend, yes, he is my best friend, and Professor Yashiro as a moderator, and Dr. Rahmadina Suci Bestari also as moderator, and all the speaker, Dr. Novita, internal medicine from Muhammadiyah Medical School, SURAKARTA, Associate Professor Yoshimune Hiratsuka from Juntendo University, Associate Professor of Eijiro Yamada from Gunma University, and Keiichiro Matoba, Jikai University. I would like to thank because we can continue the webinar, and we can implement our collaboration between the Association of Muhammadiyah Medical and Health Education and Japanese Medical School International Assembly, I think it's very important. Webinar today is the second one, and the first one maybe several months ago, and I think it's better if we can continue our collaboration not only in the medical education and research, but also in medical services if possible, and student exchange and the lecturer exchange. Thank you again. Thank you very much for everything. Greeting from me.
Okay, thank you very much, Dr. Wawan.
Yeah.
He's my great good friend. Thank you so much. Well, the 4 remarks. Thank you very much. Wonderful remarks. Now that I would like to move to the science section, I ask the Muhammadiyah moderate the flowing session. Suki, please.
Okay. Thank you, Prof. Yashiro, for the opportunity given to me. Ladies and gentlemen, students and lecturers, I am the moderator of this occasion, second international webinar, Current Treatment for Diabetes, What Medical Students and Young Doctors Need to Learn. It is held by collaboration between Japanese Medical School International Collaborative Assembly and Association of Muhammadiyah Medical and Health Education. First, let me introduce myself. Next. I am Prof. Madina Suci Bestari, born 30 years ago. I got my medical degree in 2010 from Universitas Brasmarat Surakarta, Indonesia. Then I got my master degree in 2014 from Universitas Gadjah Mada, Yogyakarta, Indonesia. Now I am lecturer of Medical Faculty Universitas Muhammadiyah Surakarta, Indonesia. My research field and community service is about parasitology, tropical medicine, helminth, malaria, larvicide, etc. In 2020, I wrote a textbook about the title Tropical Medicine Basic and Clinic. Some of my international papers are Untitled in 2020 at International Summit on Science, Technology, and Humanity, ISET, and about larvicide in 2019 at International Conference Tropical Medicine and Infectious Diseases, Kuala Lumpur, Malaysia. My international experience was become judge of Cyberjaya International Undergraduate Colloquium for Health Science in 2021 and become supervisor of mobility students of Medical Faculty UMS at Medical Faculty UOC Malaysia. My achievements are as first winner of oral presentation call for paper in 2020 and 2021. Enough about me, students and lecturers. Let's move to plenary session. Okay, students and lecturers, we will have 2 sessions. Each session consists of 2 speakers. On first session, we will have 2 speakers. The first speaker is Assistant Professor Dr. Novita Nurhidayati Mahmuda, M.Sc, Sp.PD, FINASIM, internist. She is from Faculty of Medicine, Universitas Muhammadiyah, Surakarta. She will deliver the topic, Recent Status of Diabetes in Indonesia. She will present it for about 30 minutes, followed by question and answer session for 10 minutes. So please type down your question at chat box, or you can ask directly later on Q&A session. The second speaker is Associate Professor Dr. Eijiro Yamada, M.D. Ph.D. He is from Gunma University Graduate School of Medicine. He will deliver the topic, Diagnosis and Latest Treatment for Diabetes. He will present for about 30 minutes, followed by question and answer session for 10 minutes. Okay, students and lecturers, this is session 1 of our agenda. Allow me to read the curriculum vitae of the first speaker. Dr. Novita Nurhidayati Mahmuda, M.Sc, Sp.PD, FINASIM, internist, born in Jakarta 40 years ago, graduated from University of Yamada, Indonesia in 2005, Yamada Indonesia in 2013, internal medicine specialist in 2015, and got fellowship FINASIM in 2020. In its lecture, academic and clinical program of medical faculty Muhammadiyah SURAKARTA. She is assistant professor in internal medicine. She is active researcher and has publication in national and international journal and proceeding. Next. And she was writer of textbook. The title is Tropical Medicine, Basic and Clinic. Okay, students and lecturers, please welcome Dr. Iin Novita.
Thank you, Dr. Dina, for the beautiful introductions. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. I would like to thank to all committee for this opportunity. I would also want to greet all of our speakers from Japanese Medical School. Welcome also to all participants from Indonesia and Japan. My topic this afternoon is about recent status of diabetes in Indonesia. I will try to share my materials. Okay. Okay, it's working, right? Okay. Okay. Diabetes is a huge burden, not only for Indonesians, but also for many countries around the world. In 2019, the International Diabetes Federation estimates that 1 in every 11 adults has diabetes. 1 in 2 adults with diabetes are undiagnosed. So many people is not known about their diabetes status. Over 3 in 4 people with diabetes live in low and middle income countries. Diabetes also spend a lot of global health expenditure. About 10% of global health expenditure is spent on diabetes. And not only diabetes, we are facing also impaired glucose tolerance. So 1 in 13 adults has impaired glucose tolerance. How about the older people? So in IDF, we found that 1 in 5 people with diabetes have already reached 65 years old. So they have many chronic disease, hypertension, chronic pulmonary disease, or heart disease. One of them are diabetes. So many older people have diabetes. How about children and adolescents? About 1 million children and adolescents around the world have also diabetic type 1. And pregnant women, also many pregnant women are diagnosed with gestational diabetes. 1 in 6 live birth is affected by hyperglycemia in pregnancy. So diabetes is a huge burden for the world. The world prevalence for diabetes, we can see that 90% of all diabetes in this world are diabetes type 2. In 2000s, the prevalence is only about 2.8. And in 2019, it became 9 already. Yeah, so it increased about 7 points. And estimated in 2030, it will be above 10% prevalence of diabetes in the world. So it increased about 25% from 2000s. And in 2045, it will be almost reach 11%. Yeah, so it increases 50% than the previous prevalence. Our country, Indonesia and Japan, are in Western Pacific region. So here we can see in Indonesia, estimated 10 million people suffering for diabetes. So it's about 6.3%. In Malaysia having trouble with this diabetes. Yeah, they are small country, but many people there with diabetes. It's almost reached 20%, 80.3%. Philippines have 8.2% citizen with diabetes, and Thailand have 7% citizen with diabetes. Diabetes also associated with increasing healthcare costs. So globally, it increased 11.2% healthcare costs because of diabetes. In our Western Pacific regions, our medical cost expenditure is increasing about 40% because of diabetes. Why the diabetic patient becoming the burden? It's not about the disease, but it's about the complication, the long-term complication. So diabetes is associated with increased risk of cardiovascular disease and increased risk of chronic kidney disease. So we know that people with type 2 diabetes are 2 until 3 times more likely to have cardiovascular than those without diabetes. And cardiovascular disease is also responsible for 50% of all diabetes-related death. The same condition is happen in chronic kidney disease. Up to 40% patients with diabetes may develop chronic kidney disease in the next 5 or 10 years. And patients with diabetes, when they are diagnosed, 61% of them have shown microalbuminuria and in their urinary examinations. Okay, is there any gender preference for diabetes? This is the prevalence for diabetes in male. So the global prevalence is 9% for male. And the female, the prevalence of diabetes in female are 9%. So both men and women have the same risk from suffering from diabetes. How about in our country, Indonesia? Yeah, this data I get from Rikesdas, Riset Kesehatan Dasar in Indonesia. In 2013, we can see that the prevalence in Indonesia is 6.9%. In 2018, it increased 2 points to 8.5%. Now, the last 2 years, 2018, it's increased into 10.9%. So there are many diabetic patients in Indonesia. If we compare with other countries, in 2019, Indonesia is number 7. Countries with many diabetic patient, we are in the top 10, number 7. Then the prediction in 2030 and 2045, we are not out of the 10 country yet, but we're still in number 7, and we step down to number 8 in 2045. So I think it's not a great achievement, right? The number of diabetic patient in Indonesia is problem because many. Other problem is about 70% of people with diabetes in Indonesia are living without knowing that they have diabetes. So it makes many patients came to seek medical services which already have complications. So it's already too late to reduce or to prevent the complications. Okay. Other problem that we are facing is people with impaired glucose tolerance. We cannot see Japan country here. So congratulations for Japan. Besides diabetes, we have another emerging problem is people with impaired glucose tolerance. This I get from EDF Atlas 2019. Indonesia is number 3. So in the future, we're going to have many other diabetic patients because now our position in number 3, people with impaired glucose tolerance. Impaired glucose tolerance is people with not normal blood glucose, but they are not fulfilling the diagnosis for diabetes yet. So we call them pre-diabetic state. Is there any Japan here? Oh yeah, welcome Japan. Yeah, I believe we have the same problem here, that we have so many people in our country who have the impaired glucose tolerance. Yeah, we have the same problem here. Okay, diabetes itself is not curable actually. What is curable is the diabetes complication that pose a great threat to patient quality of life. The diabetic improve the eye, give a consequence in renal functions. Yeah, sometimes patients have to lose their limb, amputations, and people with diabetes also have a higher risk of developing periodontal disease. Yeah, not mention the heart disease because of diabetes, and pregnancy. Pregnant women with diabetes should manage their blood glucose to avoid long-term consequences for them and for their children. So diabetes increasing the morbidity and mortality of mother and newborn babies. Okay. These complications had bring heavy economic burden to the patients. We can see it here. This is the 5 major complications in diabetic. Yeah, for women, most lifetime direct medical cost in patient diabetic is spent with stroke management. Number 2 is for nephropathy management. Number 3 for neuropathy management, then retinopathy and coronary heart disease. So we spend a lot of money treating these complications. And for men, the first one is also treating stroke disease. Yeah, this spend a lot of medical costs treating the stroke complications. Number 2 for men is coronary heart disease. Yeah, number 3 is nephropathy, neuropathy diabeticum, nephropathy diabeticum, and retinopathy diabeticum. Okay. This is the number of cases catastrophic disease, which I take from our Kementerian Kesehatan of Republik Indonesia. We have the 8 disease that spend a lot of our resources, of medical costs. The catastrophic disease is number 1 is cardiac disease. So until December 2020, there are 11 million of Indonesians suffering from cardiac disease. Cancer disease, there are 2.2 million people suffering from cancer disease. 1.7 million people suffering from stroke, and 1.6 million people suffering from kidney failure. So we can see that here, cardiac disease, stroke, and kidney failure, 3 of these diseases are actually the complication of diabetes mellitus. So most of cardiac disease patients have also diabetic, besides hypertension, of course. Most of stroke patients also had diabetes, and diabetes nephropathy is the cause of hemodialytic patients, number 2. Number 1 is hypertension. So our government give a lot of medical costs treating this disease because of diabetic complications. Yeah, what cause of the most death in Indonesia? Yeah, our cause of death are classified into 3. Cause of death because of communicable disease, maternal and neonatal and nutritional disease. Cause of death because of non-communicable disease, including diabetes, coronary heart disease, stroke, etc. And cause of death because of injury. In 2010, number 1 cause of death is stroke. Number 2 is ischemic heart disease. Number 3 is tuberculosis. Diabetes is number 5. Number 6. Above diabetes is diarrhea disease. So here we can see that the infection disease, tuberculosis, diarrheal disease, neonatal disorder, and lower respiratory infection play a great role in causing the death in Indonesia. We see the condition in 2019. Yeah, the first cause of death in Indonesia is still stroke. Yeah, Stroke still number 1 cause of death. Number 2 is ischemic heart disease. Nah, diabetes is increasing from number 6 to number 3. Number 4 is cirrhosis. The tuberculosis is stepped down to number 5. The diarrheal disease is stepped down to number 7. And low respiratory infection stepped down to number 10. And our neonatal disorder is not above 10 anymore. So the good news is our country are successful in declining number of disease because of infection disease and neonatal disorder. But the sad is, on the other hand, we are facing non-communicable disease as our main problem and main cause of death. We can see the presentation change here from 2009 to until 2019. Case of death because of stroke is increasing 25%. Case of death of ischemic heart disease is increasing 28%, and diabetes is increasing almost 50% for cause of death. So diabetes is, it's a very important disease now in Indonesia. We can see other chart. What risk factor drive the most death and disability in Indonesia? We can divide it into 3 also, metabolic risk, environmental risk, and behavior risk. In 2009, the first risk factor that drive the most death is malnutrition. In 2019, the most risk factor that drive the most death is hypertension. So it's chronic disease. Yeah, diabetes is right here. In 2009, it's number 6. High fasting glucose. In 2019, it raised to number 4. Yeah. So we can see here that our main risk of death in Indonesia is mainly about the metabolic risk and behavior risk. Yeah. So to prevent this case of death in Indonesia, we have to change the lifestyle so it can decrease the metabolic risk and behavior risk. Okay. Okay. Here's the chart about diabetes prevalence in all provinces in Indonesia. So in every province, the prevalence is almost same, yeah, and it increasing every year. We can see that the blue box here is in 2013, and the orange block here is in 2018. Yeah, so every province has increasing the prevalence of diabetes mellitus, except from Bali. Bali can decrease the prevalence of diabetes mellitus, but other province is increased. Number 1 province that give many diabetic patients is Jakarta, our capital city of Indonesia. Then Yogyakarta, Kalimantan Timur, so big city give increased prevalence in diabetic patients. Diabetic prevalence according to gender and age group. So including to gender and age group, there is no significant difference between men and women in Indonesia to have diabetes. Here we can see that for women, we have a little bit slight more increasing prevalence than men. Yeah. Then according to age, most of our diabetic patients is between 55 until 65 years old. So almost entering the geriatric age. In Indonesia, 16 or 60 already enter the geriatric age. And then the second is with people with 65 until 75 years old. Yeah. So yeah. Okay. Diabetes prevalence according to educational background and residence. Yes, so the higher the background, the educational background, the prevalence is of diabetes mellitus also increasing. So we can see it here. People go to academy or university, have prevalence of diabetes more than 2. Yeah, it's higher than people who are only get their medication, their education, senior high school or elementary school. They're only above below 2% of prevalence. According to residents, yeah, more people with diabetic live in urban area. Yeah, compare with people live in rural area. So the lifestyle is playing a role here, right? Yeah, we can see that the lifestyle in urban people is different from people in rural area. Obesity also play a huge role in increasing diabetes prevalence. Our number of people with diabetes with obesity is increasing from 15% to 21%. So it's significantly increased. Yeah, and then we also have to pay attention on how people like to eat sweet food and sweet beverage. I'm sorry. Yeah, this is we can see that most people in Indonesia like to eat sweet food. 47, yeah, almost 50% of Indonesia like to eat sweet food, and more than 60% of Indonesian people take sweet beverage, yeah, more than 1 time a day. Yeah. How about the physical activity? Yeah, well, at last we have the good news here that most of Indonesian citizens say that they are daily active, 73%, and most of Indonesian people report that more than 60% of them doing enough exercise every day. Yeah. Okay. There are some ethnic difference for people in Asia. Our diabetic patients in higher prevalence for diabetes type 2. And our diabetic patient also a higher rate of microvascular complication, retinopathy and nephropathy. Our diabetic patient in Asian give higher A1C level as at baseline. Yeah, so we have significant risk factor for complication to type 2 diabetes, and most of Indonesian people like to eat high carbohydrate food. Yeah, this is different in dietary habit with Japan, and also different metabolic response with insulins. Yeah, because insulin therapy is so very individual. So this is the unique characteristic for DM type 2 in Asian population. Normally we have low or normal body mass index. We have already beta cell dysfunction earlier in diagnosis of diabetes, as our patients type 2 DM with more younger onset. We have a preference of high carbohydrate diet and high postprandial plasma glucose. Okay, this is the median A1C diabetic patient in Indonesia. So there are 2 research in 2012. It consists about more than 2,000 subjects. The mean A1C patient in Indonesia is about 8. Yes, so it's quite high. Yeah, so and people with diabetes that have the A1C under 7 is only about 30%. Yeah, almost all of our diabetic patients cannot gain their target of glucose. Other research, yeah, diabetic patients in 783 subjects, the median A1C is not yet far. It's still 8. Yeah, so it's the same in 2000, the previous research, and people with A1C control under 7 is just only 28%. Yeah. Okay. Why diabetes control is very difficult in our country because we know the pathogenism of hyperglycemia in people with diabetes is very complex. So it is not only about the beta cell dysfunctions, but also about the colon abnormal microbiota and immune dysregulation and inflammations. There are also insulin resistant factor. Yes. So the hyperglycemia is very complex. So each patient, to reach their blood glucose goal, we need to take more than one medicine, 2, 3, or maybe 4 combination of medicines. Yeah, even complex insulin regimens. Other factors are the complexity and progression of diabetes itself. Yeah, you can, as we talked previously before, that 70% of our diabetic patients are not aware that they have the diabetic. Then there are also factors from patients' complements, doctor factor. Yeah. Usually doctors don't have time to educate their patients, and also the health service system. Yeah, not all the therapy for diabetes is covered by the insurance in our country. Okay, so we have problems and challenges of diabetic management in Indonesia. We have high and increasing prevalence of pre-diabetic and diabetic patients. Most patients do not realize that they have the diabetes. Many patients come already with complication, high burden of micro and macrovascular complication, and expensive treatment for complication therapy, although we have limited resources. Strong belief that type 2 diabetes can be prevented. Yeah, its complications will be also prevented. So one said that the prevention is better than cure. So we have to make intervention in pre-diabetic state, so patient can achieve clinical remissions. The sooner, yeah, the better. And number 2 is to normalize the glucose homeostasis in patient with pre-diabetic population, so they can reduce the cardiovascular and other chronic complications. Number 3, we have to early encourage for healthy lifestyle, because healthy lifestyle is very effective in reducing risk factor to become pre-diabetic and diabetes. And number 4 is we have to still continue intervention for diabetic patients. So early detection in diabetic is very good. Examination of diabetes should not wait for sign and symptom because it will be too late. Yeah, there are many people with diabetes diagnosis, but we are not know there are so many people, other people already with pre-diabetic status. So we do have to take the opportunistic screening to find as many people as possible, people with impaired glucose tolerance. So when they are in pre-diabetic state, yeah, we have to make intervention or lifestyle interventions. This is the criteria, what kind of person that you have to be screening for diabetes. Screening for diabetes should be considered in overweight or obese person that have the clinic this following risk factor. And then patient with A1C more than 5.7 should be tested yearly. Women who are diagnosed with gestational diabetes should have lifelong testing at least every 3 years. For all other patients, testing for diabetes, screening for diabetes should begin at age of 40. If the results are normal, the testing should be repeated at minimum 3 years interval, or maybe frequently depending on the indications. And we have to give lifestyle recommendation for all patients, not only for diabetic patient, but all patients with obesity, with first-degree relative with diabetes, for pregnant women. All people should follow the lifestyle recommendations: nutrition, physical activity, sleep well, good mental health, and no smoking. Okay, blood glucose monitoring is also fundamental for diabetic treatment. With blood glucose monitoring, a person will provide data for diabetes, so they can so they can adjust their medication by themselves. Yeah, and it gives also information about how well they are doing. Yeah, and it's used by healthcare provider to evaluate and make change in diabetes regimen of the patient. So we encourage our patient to have their own blood glucose tester at home. Yeah. As a conclusion, diabetes in Indonesia remain a big challenge. Early detection will help prevent further diabetes progression and its complications. Behavior changes should be promoted toward healthier lifestyles, and treatment should be tailored to individual based on individual preference, prognosis, and comorbid. Okay, I would like to add some slide about COVID pandemic. Yeah, we can know that diabetes is number 2 comorbid in COVID infections. Number 1 is hypertension, number 2 in diabetes. Same condition happened in New York. Leading comorbidity among COVID-19 deaths in New York is number 2 is diabetes. The same happened here in Indonesia. Yeah, most of our COVID-19 have comorbid. The first one is hypertension, and the second one is diabetes. There are one good research and interesting research. This is from research from patients who are treated in Wisma Atlet Kemayoran, our main building for isolation in Jakarta. So it says that hyperglycemic can induce by COVID infection with or without present diabetes. So it's very interesting. Yeah, so it can increase our prevalence of diabetes in the future. So what is the prevention for diabetic patients during this COVID pandemic? First, diabetic patients have to contact information of their healthcare provider. They should have adequate stock of medications and supply for monitoring blood glucose. They should have enough stock for simple carbohydrate to manage low blood glucose, and if necessary, if possible, patient with diabetes also have to provide glucagon on cotton strip in case of poor glycemic control. So diabetes and COVID, people with diabetes are not more likely to get COVID-19 than the general populations. Diabetes is one of the highest group for developing severe illness from COVID-19, and the risk of having worse outcome is similar in people with diabetes type 1 and people with diabetes type 2. This is my reference. Terima kasih. Arigatou gozaimasu. Saya kembalikan kepada Dr. Romadina.
Yeah, thank you, Dr. Iin. Thank you for the complete explanation about recent status of diabetes in Indonesia. Students and lecturers, we have learned about epidemiology and burden, prevalence in male and female. Then it's interesting that Japan is not among top 10 that increasing number of diabetic patients, but among top 10 countries with impaired glucose tolerance. Same with us. Well, it's true that Indonesians like sweet food, including me, Dr. Iin.
Yeah.
Okay. Students and lecturers, we enter Q&A session for 10 minutes ahead. You can ask directly or type in the chat box. Thank you, Mr. Ari, for the presentation about question and answer. Is there any participant that have give the question in this session? Sorry, I can see if there is a participant that raise their hand. If there, please to unmute and then ask about
the IT team will share the questions.
Okay, Alessandro MPP have raised hand. Two participants have raised hand. Alessandro, please.
Yes. Yeah. I'm sorry. I cannot turn on my video. Yes.
Okay.
Yes. Okay. Baik. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Let me introduce myself. My name is Alessandro Milano Pratama. Dr. In, I would like to ask a question. So before I join this seminar, I actually read about hypermetabolism. Hypermetabolism is, well, in increase of metabolism is in common, yes. In common is about increase of metabolism. Does hypermetabolism can decrease the chance of diabetes, or maybe it has no differences in normal people with normal metabolism? Because I read here is also that in hypermetabolism in some cases it also decrease the level of sugars in their body. Maybe that is my question. I hope you understand the question well, guys. Alhamdulillah, wassalamualaikum warahmatullahi wabarakatuh.
Okay, please, Dr. In, you can answer the question of Alessandro.
Okay, thank you, Alexander, for the questions. If you mean the hypermetabolism is, for example, people with hyperthyroid, is it right? Yeah, yeah. People with hyperthyroid, or we can also say thyroidism. They are at the hypermetabolic state, but it is not healthy metabolic system. So our to maintain our milieu internal going well, we have to have normal metabolic, not low, also not hypermetabolic. The hypermetabolic also consume calories, yes, glucose, yes, but on the other hand, it make our body thin. So people with hypermetabolic is a great risk to be hypoglycemia. So we cannot say that hypermetabolism can be decreasing the incidence or the prevalence or diabetes. It is not that way. Diabetes is a metabolic syndrome that make our body different way to manage glycemia. Our body will be hyperglycemia. In hypermetabolic, our body will take the risk to be hypoglycemia in a different way. It is not a way to decrease the incidence of diabetes mellitus. Yeah, is it right?
Okay, Alessandro, is there any feedback? I think it's clearly enough. Dr.
Yeah, so it's different
Yes,
between hypermetabolism and diabetes.
Yes. Thank you. Thank you for the answer, Dr. In. I understand well. Alhamdulillah.
Okay. There's the answer from Dr. In for the first question by Alessandro. Thank you for the question and answer. And the second question is from Rizky Febrian. Are you gonna ask by yourself, Rizky, please?
Yes, Doctor. Bismillahirrahmanirrahim. Good afternoon, Doctor. Let me introduce myself. My name is Rizky Febrian. And why I ask my first question. In the presentation, mentioned that the global prevalence of men and women in the same, which is 9%. What about diabetes complication, such as chronic kidney disease? It is the same for men and women to be chronic kidney disease. And the second question is, in the presentation, it was explained that in the developed countries and those that tend to have a sedentary lifestyle have a high number of diabetes cases. Can countries that still use traditional lifestyle, such as food and physical activities, prevent an increase in diabetes cases? Thank you, Doctor.
Okay, thank you, Rizky. So there are two questions. Dr. In,
okay.
Are you ready to answer?
Okay, there is no difference in prevalence of diabetes for men or women. but there are different patterns of complications. Number one complication for men, also women, is stroke, cardiovascular disease. And number two for women is nephropathy diabetic, but for men, number two is coroner, penyakit jantung coroner. So it's a little bit different. About people with chronic kidney disease, which have to go through a hemodialysis, the prevalence of kidney failure in Indonesia actually for men is a little bit higher than women. So for men is 0.3%, for women is 0.2%. So it's a little bit difference. Our main risk factor for kidney failure in Indonesia, number one is still hypertension. And most patients with hypertension is men. Number two is diabetes mellitus. We had also glomerulonephropathy chronic disease and obstructive disease that can be main risk factor for chronic kidney failure. Okay, is it clear for your first questions? And your second question is about, what is that again, Dr. Dina?
Second question is about, Fabian, can you ask again?
I repeat my question, doctor.
Okay.
In the presentation, it was explained that in developed countries, it does tend to have sedentary lifestyle, that a high number of diabetes cases. Can countries that still use traditional lifestyle, such as food and physical activity, prevent an increased diabetes case?
I'm sorry, I cannot find your idea. So the sedentary lifestyle is one of the risk factor to be pre-diabetic state and also to be diabetes patients. How to prevent it? Is that correct?
Can traditional lifestyle pattern such as food and physical activities in traditional lifestyle prevent the increase of diabetes case?
Okay. Well, as I assume, what you mean with traditional lifestyle is people living in rural area. Is that right? So I've mentioned in my PPT that most of diabetic patients are living in urban area, and there are fewer of them are living in rural area. So, well, I think we can conclude by ourselves. They have the different pattern of lifestyle. People living in urban or people living in rural area. Their daily activity maybe, or their type of consuming food, yeah, and other activity that can reduce the prevalence of diabetic. So. Our suggestion is the healthy lifestyle should be done by everyone, not only people in rural, but also people living in urban. For us, mainly of us people living in urban, it might a little bit difficult to to do that kind of living, because we go to work by car or maybe by motorcycles, different with people in rural. They go everywhere walking or cycling, yeah, and number of people who go to smoking or drinking alcohol may be lesser in rural area. So the data gives that conclusions. So maybe we can adjust their lifestyle to our lifestyles in order to prevent ourselves of becoming the pre-diabetic or diabetic patients.
Okay, Rizky Fabian and Dr. Iin, I think it's explanation, right? Okay, thank you for the question and answer. Okay, Dr. Iin, this is the end of first speaker session. Thank in advance. Students and lecturers, our second speaker is about to present. Before that, allow me to read the curriculum vitae of the second speaker. Next. Associate Professor Dr. Eijiro Yamada, born in Yokohama, Kanagawa, Japan. He got medical degree in 1999 from Gunma University School of Medicine, Gunma, Japan. He got Ph.D. degree in 2005 from Department of Medicine and Molecular Science, Gunma University Graduate School of Medicine, Maebashi, Gunma, Japan. Then, from 2008 until now, he had several postgraduate training, right?
Yes.
In 2008, he got postdoctoral fellow, Department of Pharmacology, State University of New York at Stony Brook, New York. In 2011, he was research associate in Department of Medicine, Division of Endocrinology, Albert Einstein College of Medicine, New York. Slide, please. In 2012, he became instructor of Department of Medicine, Division of Endocrinology, Albert Einstein College of Medicine, New York. Then he went back to Japan as lecturer in Gunma University Hospital until present. Dr. Yamada got honors and awards as follows. In 2002, he got Young Investigator Award from the Japan Endocrine Society. And in 2017, he got Investigator Award from Asian Association for the Study of Diabetes. Dr. Yamada's professional affiliation are membership in Japanese Society of Internal Medicine, Japan Diabetes Society, and Japan Endocrine Society. The area of research interests are diabetes, insulin signaling pathways, diabetic kidney disease, sarcopenia, autophagy, integrative physiology. That's about Dr. Yamada. Are you ready, Dr. Yamada?
Thank you very much for your kind introduction, Dr. Bastoni. And hello, everyone. Could I share my slides first? This one, I think.
Okay, please, Dr. Yamada.
Okay. So, my name is Eijiro Yamada from Division of Endocrinology and Metabolism, Department of Internal Medicine, Gunma University Graduate School of Medicine. And first of all, I'd like to thank the people who gave me the opportunity to have a presentation. Today, I'm going to present diagnosis and latest treatment for diabetes. Yeah, you can see here. Okay.
Yes.
Okay. Thank you. And these pictures represent patients with diabetes. Which patient do you think are suffering from diabetes? This one, this person, or this person. In other words, what is your image for the diabetes? So to get started my presentation about diabetes, I'm going to present the reason why blood sugar will rise. When we think about diabetes further, we have to think about blood sugar and the carbohydrate, right? So let's think about blood sugar and its source, carbohydrate. As you know, carbohydrate is one of the three main sources of nutrients, right? And the normal range of blood sugar is around 100. It's complicated, but it's around, should be around 100. And diabetes was defined as blood glucose level more than 200 milligram to our after a glucose load, like 75 gram carbohydrate. And it is an energy source. And at the same time, it can cause vascular complications so that usually very tightly controlled in the body. and its deficit leads to diabetes, right? And this definition of diabetes is kind of easy to understand, right? The 100 milligram per deciliter, but the deciliter 100 milligram deciliter is hard to imagine because of deciliter which is not used regularly. Therefore, let's convert it to gram per liter. Gram per liter. So the milligram is 0.1 grams, and deciliter is 0.1 liter, right? So that it's gonna be 100 milligram per deciliter is 1 gram per liter. Then how much is the total body? How much is the total blood volume? Like, for example, body weight 50 kilograms. Can you imagine? It's like the 8% of per volume. It's weight per volume, and therefore around it's gonna be 4 liter in the body blood. And how much is the total blood sugar in the whole blood? Then the 1 times 4, so it's gonna be 4 grams, right? So let's say how much is the so now we know that the amount of sugar in the whole body is 4 grams only, right? And the scoop of sugar is 4 grams, so it's a very tiny amount of sugar in the whole blood. Actually, so that's why the easy. We can imagine that how easy it is going to get blood sugar up, right? And for example, the picture. This picture shows how many sugar cubes is added in the Coke, and it is more than 15. So you can imagine also if you drink this one, then the blood sugar is going up, right? And finally, we know that the amount of sugar is in the body, whole body is only 1 scoop of sugar. Let's think about it on another way. The blood concentration of Coke is 55 gram per 500 milliliters, which is going to be 11,000 milligram per deciliter. If our body cannot metabolize the carbohydrates, the blood sugar is going up to 11,000 milligram per deciliter when we drink Coke. In this regard, we actually experienced the patient whose blood glucose was 2,500 in our hospital. It's a maximum level of blood sugar. We now know that it is not an impossible value, right? And let's talk about carbohydrate more because I like carbohydrates food. So this slide includes the delicious Japanese food. Do you know this? I don't know. You guys know these kind of food. Which food do you feel full stomach? And which food do you think will raise your blood sugar? Can you imagine that? This is sweet red pan. In Japan, we call the ampan, the fried chicken. This versus sushi for one versus steak set meal, and a burger, French fried diet pork versus beef bowl versus pork cutlet curry rice. Which food do you feel full stomach, or which food will raise your blood sugar? It's yes.
Yamada? Yes, excuse me for interrupt. Can you show the presentation? Yes.
Presentation.
Slideshow.
I think it's gonna be.
Okay, thank you.
So I thought it's gonna be okay. Then Anyway, you can imagine that. So these are the answers. Can you see the slide?
Yes.
Okay, thank you very much. And let's talk about sweet red bun, bean bun versus fried chicken. The calories are 280 kilocalories versus 250 kilocalories, respectively, which means the feeling of fullness is not different between those, right? The calories are almost the same. But the carbohydrate is 15 grams versus 10 grams. Therefore, you can easily imagine that blood sugar level is more likely to rise when eating the ampang, this one. Sorry. And let's think about the sushi for one versus steak set. The calories are 500 kilocalories versus 11,000. 1100, sorry. And respectively, which means feeling the fullness is much more when eating steak set, right? And but carbohydrate is 80 kilogram versus 45 grams. Therefore, the increase of sugar, blood sugar level is less when eating steak set. We can think it in the same way: burger, French fry, Diet Coke versus beef bowl and pork cutlet curry with rice. The calorie is like here, and burger, French fries, Diet Coke is only 700 kilocalories, but carbohydrate is 60 grams, which is less, but surprisingly, the French fries is more, the burger has 36 grams, and the French fries 23 grams. So French fries is the less has carbohydrate, but we cannot imagine when we eat French fries, it's easy to get the blood sugar going up. Let's talk about type 2 diabetes. Actually, the first picture we saw in the first slide is a patient with type 2 diabetes. You can imagine, actually. Type 2 diabetes is caused by both environmental factors like overeating, like lack of exercise, and genetic factors. Obesity caused by environmental factors will lead to insulin resistance, but usually insulin resistance alone does not cause diabetes. When deficit of insulin secretion caused by genetic factors occurs with insulin resistance, patients are going to be type 2 diabetes. As you might know, the former presenter said that type 2 diabetes is increasing globally in Japan as well as Indonesia. And now it's going to be a big social problem all over the world. But we now have a lot of treatment options for type 2 diabetes. This slide shows the ADA, American Diabetes Association Type 2 Diabetes Management Algorithm. As you can see here, we have a lot of treatment options for diabetes, like GLP-1 and SGLT2 inhibitors and DPPO inhibitors, like that. And as you can see here, we can have a lot of treatment options, but I would like to emphasize that this description, but I would like to emphasize that this description here is the most important point, actually. This says that to avoid therapeutic inertia, reassess and modify treatment regularly we need. Do you know about the therapeutic inertia? So based on the idea that diabetes is asymptomatic disease as well as caused by lifestyle, it is reported that patients are not receiving proper treatment. As you can see this graph, only 59.6% patients whose hemoglobin A1C is more than 9%, which indicates really bad control, have treatment intensification. No intensification for 44.4% for patient with more than 9% hemoglobin A1C. And clinical inertia, this is a clinical inertia, right? You didn't, the clinician or patient didn't do anything for the bad control. Here's a clinical inertia. And the clinical inertia is caused by the physician factors and patient factors and office system factors. And the physician, patient factors deny having the disease, believe disease is not serious, low healthy literacy, cost of medication like that. But we have to know is that the factors, the patient factors are only 30%. And the other is caused by physician factors or office system factors, like getting setting pathologies, fail to initiate treatment, fail to titrate treatment until goal achieved, or reactive rather than proactive care. So we have to think about that. So up to here, we understand that diabetes treatment actually has kind of improvement. Are there other development? Today, my talk is about the development of diabetes. So I'm going to be talking about advanced diabetic medicine, about the advanced diabetic medicine. Do you know who are they? Yes, the man is a former president of USA, Trump, right? And the other women is May, the former president of England. Actually, she is a patient with type 1 diabetes. And do you know this device she wears? The device she wears was CGM, the continuous glucose monitoring. Actually, she used both arms, so we have a scale of the CGM here also. So continuous glucose monitoring is a device that continuously measures the blood glucose level in the intestinal fluid by a sensor inserted under the skin. Usually, or before, if you want to check the blood sugar, usually the presenter shows blood sugar, you might pinch fingers to take blood. And using the device like this for self-monitoring of blood glucose, right? But now we have a system like this kind of stuff. This is inserted to the skin and inserted into subcutaneous tissues in the skin and estimates blood sugar in the fluid. The advantage of CGM is not only harmful, it's going to be a little bit harmful, right? So it's not so much harmful. And if you setting, then you don't have to be harmful anymore. So, and we can tell, and also we can tell the wave blood glucose continuously, which we can never do before. If we use the SMBG the system, then you can just know the blood glucose the 4 times less than 4 times a day, like that. But if you use the CDM, you can know the blood sugar more detailed. even CGM will check the blood sugar indirectly. The values are only difference. But recently, the accuracy of CGM is going to be the one of the SMBG, which very progress. This is the year, like 2005. We have the glucose watch or Medtronic RT Guardian. The math means the accuracy of the CGM. It's not so accurate, but if you go to the 2015, the CGM is very accurate. It's gonna be the same SMBG accuracy. So some CGM system doesn't need the SMBG self-monitoring blood sugar anymore. So why will we have to use CGM? This slide shows the meta-analysis data. As you can see here, hypoglycemia increases the risk of the CV event. This is the CV event, and mortality. So if you have a hypoglycemia, then the mortality is going up. So now we know that good hemoglobin A1C does not necessarily mean mitigating the CV event, but hypoglycemia does strongly correlate CV event for total mortality. Here is the first report showing the death in bed syndrome with CGM. So this web shows the blood sugar, and this patient this patient died from the hypoglycemia here. And after the series of insulin injection, he had a series of injection here, and CGM teach us that in bed syndrome here. So those are the CGM data from patients actually. Which do you think is the best hemoglobin A1C, which might represent reduce risk of microvascular complications, CV events? This one, this one, this one. So hemoglobin, which one is hemoglobin C is better? Actually, this patient, CGM, this patient has a hemoglobin C 6.3. So I think most of the people cannot imagine this. The patient has a hemoglobin C 6.3. I think this is we can imagine. This is kind of we can imagine, but this is it's hard to imagine that the patient has a hemoglobin A1C 6.3. Then which one is the highest risk of CV event? Let's say CV event is caused by the glucose variability. We have to ignore this region. Actually, 70 to 180, which is the good blood glucose concentrations. And after hide this region, you can imagine that you can see that this person has a higher glucose variability more than the other patients. So maybe this person is hemoglobin A1C is 6.3, but he has a highest risk of CV event. So furthermore, here we have a big progress for insulin therapy. As Professor Yashiro said, it has been 100 years ago since the insulin is invented. With the experiment of this dog, the who is removed pancreas, we developed insulin, right? And the insulin can treat type 1 diabetes. This cat is actually This kit from first slide is actually the type 1 diabetes, which is incurable disease before taking the insulin, and he's cured, but he's living. He can live after treatment. And before we had to use this amount of pig pancreas to make 1 bottle of insulin, but now we can make it easily. So many patients, I know the problem in the world, but most patients easily receive insulin therapy. But patients with type 1 diabetes still point to the body with 3,000 needles a year, actually. This photo shows the needles used for 1 year. And blood glucose measurement is also required. So they have to pinch their bodies regularly. To overcome this problem, we now have insulin pump therapy. Patients with insulin pump can inject insulin with a touch of button. You can touch here, and the insulin can easily inject it. Moreover, it can be used with CGM. This is the data, the insulin pump with CGM. This will actually show the blood sugar levels, and the lower panel shows the insulin injection. And you can behave with the real-time blood sugar data, actually. And actually, also insulin pump is now itself can stop with hypoglycemia. This insulin pump can recognize hypoglycemia, and the insulin pump will stop after that. So this blue part is the insulin injection is stopped automatically. So the hypoglycemia is kind of inhibited here, like here. So this kind of the innovations happened in the diabetes. This slide shows the innovation for insulin pump therapy. Actually, in Japan, this hybrid closed loop system, insulin pump can be used from this month. Anyway, diabetes medicine has infinite possibility for the future. This slide shows the development of oral hypoglycemic agents in Japan. As you can see here, we have a lot of medicine available in Japan. I actually became medical doctor in 1999. At the time, we have less the treatment option, but it's gonna be really more than before. And advance in treatment also lead to the advance of the way of thinking about diabetes treatment, since we have a lot of treatment options. This slide shows the goal of treatment of diabetes in Japan. It's gonna be says the Japan Diabetes Society says. Before the goal was Before the goal was just control blood sugar, actually here, or hemoglobin A1C, and prevention of the diabetic complications, like here, the home goal. But now we say the goal is good per patient's life. To achieve this goal, we have to think about the comorbidities like sarcopenia, frail dementia, cancer. And we also have to think about patient stigma here. Do you know the stigma of diabetes? So the stigma is like this slide shows the stigma. Actually, based on the idea that diabetes is lifestyle disease, they call it lifestyle disease. So not only the patient, but all the people might think diabetes is a disease only caused by the lifestyle, and the patient are not good persons like that. So this thinking way is making patients stigma. So indeed, many patients with type 2 diabetes feel those kinds of stigma, actually. So this stigma leads a patient is not treatment for diabetes. So to avoid the stigma, we especially physicians have to have the advocacy for patients together with everyone. In order to this, we join the patient association activities, and these there's a lot of the activities before the COVID-19 actually, and this kind of activities are very important to avoid the advocacy, to do to feel advocacy. And this slide is the last slide. American Diabetes Association says goals of care for diabetes is prevent complications and optimize quality of life. I like this slide since they said the life is cycled. The patient having the cycle. And they have a life and the experience. Being employed, getting married, pregnant, raise their children, divorce, or care the parents. The control might not always good because they're having a life. So, but we have to think that diabetes is a chronic disease and does not mean having complications immediately. Not only evidence-based medicine, but also the narrative-based medicine. Talking with patients is very important for care patients with diabetes. Thank you for your attention. I'm sorry, the presentation is not so good. The slides are going to.
Your pronounce is good, I think. Thank you for the great presentation about diagnosis and latest treatment for diabetes. Students and lecturers, we have learned about the rising of blood sugar, risk factors of type 2 diabetes, ADA algorithm, clinical inertia, continuous glucose monitoring, CGM, then future medicine in diabetes, development of oral hypoglycemic agent, advocacy is necessary for diabetes, and decision seeker for patient-centered glycemic management in type 2 diabetes. Okay, students and lecturers, we enter question and answer session for Dr. Yamada. This is the first question, Dr. Yamada, from Angelina Ayosila. The question from Angelina. Angelina Ayosila Nabila Putu Pratomo. She asked about, is it okay to eat fruits for a diabetic patient because it is also contain carbohydrates? And is it possible whether fruits can be used to replace other carbohydrate sources? Please, Dr. Yamada, answer the question.
Okay, thank you for your questions. Actually, it's very important because the Japanese people like the fruit also. But you might know, the patient can eat fruits also. But you cannot eat too much fruit, right? Like in Japan, we say that like half of the big fruit is okay to the patient. That's going to like a 20 gram carbohydrate actually. So the up to 20 gram carbohydrate from the fruit, the patient can take the coating like that. And you don't have to exchange to the other carbohydrate actually, but in the fruit we have 20 gram carbohydrate, up to 20 gram carbohydrate. It's gonna be a good control for the diabetes actually, I think. Thank you very much.
Okay, thank you, doctor. So it's safe for diabetic patients to eat fruits.
Mm-hmm.
Then the second question comes from Ihsan Novianto. What is the percent change that a person will recover from diabetes? How to reduce the chain of getting diabetes due to heredity? What prevention can be done to reduce the rate of death from diabetes?
Oh, thank you very much. It's gonna be a very difficult, hard question, right? I think the first point, the most important point is everyone knows about the diabetes. Actually, that this is the starting point. If we don't know the enemies, we can't fight, right? So we should know what is diabetes. Everyone should know the diabetes itself. And if you know the diabetes, then you watch out, right? So maybe the popular, I don't know the in English, but population research. Do you know the population research? Like using the media or using the associations, propaganda, what we gonna say, the diabetes is this kind of disease and we should watch out or something like that. Maybe the Japanese patient knows the diabetes more than before. So that's why they're gonna watch out about the diabetes and it's decreasing, I think. So the first point, I think the treatment progression is also important, but actually the patients, not patient, but the people's the thinking way is more important, I think. Thank you very much.
Okay, thank you, Dr. Yamada. Okay, thank you for the participants for the questions. There are still questions actually, but we will deliver it in comprehensive discussion, Dr. Yamada.
Thank you very much.
This is the end of second speaker session. Thank you in advance. Okay, students and lecturers, we are going to in second session of this webinar. Slide, please. Okay, the session consists of two speakers, the third and fourth speakers. The third speaker is Associate Professor Dr. Yoshimune Hiratsuka, MD, Ph.D. from Faculty of Medicine, Juntendo University. He will deliver the topic, Present Situation of Diabetic Retinopathy in Japan. The presentation will go in about 30 minutes and Q&A session for about 10 minutes. The fourth speaker is Associate Professor Dr. Keiichiro Matoba, MD, Ph.D. from GK Medical University School of Medicine. He will present the topic, Diagnosis and Management of Diabetic Nephropathy. Okay, students and lecturers, this is second session of our agenda. Allow me to read the curriculum vitae of the third speaker. Associate Professor Dr. Yoshimune Hiratsuka, MD, MPH, Ph.D. He works in Department of Ophthalmology, Juntendo University School of Medicine. He got medical degree in 1992 from National Yamagata University Medical Department, Yamagata, Japan. In 2000, he got MPH from School of Public Health, Johns Hopkins University, Baltimore, US, and PhD degree in 2002 from Juntendo University School of Medicine, Tokyo, Japan. From 1992 until now, Dr. Hiratsuka had some professional employment as resident, then medical staff in Juntendo University, certificate in Community Eye Health, Institute of Ophthalmology, London, UK, as Associate Professor, Juntendo University School of Medicine, Board of Trustees, Japan Ophthalmologists Association. Senior Associate Professor, Juntendo University School of Medicine, Section Chief, National Institute of Public Health, and Chief Senior Researcher, National Institute of Public Health. Then from 2015 until present, Dr. Hiratsuka is Senior Associate Professor in Juntendo University School of Medicine, Japan. Students and lecturers, that's about Dr. Hiratsuka. Let's have a nice moment to study from Dr. Hiratsuka. Are you ready, Dr. Hiratsuka?
Oh, yes, I'm very ready. Thank you very much for your kind of too much, but very kind introduction. And so let me share my slide. This is the one, right? Okay, can you see my slide? Is it okay? So,
yes.
Okay, thank you. Let me start my presentation. And I'm Dr. Yoshimune Hiratsuka, working at Juntendo University, Tokyo, Japan. And I'm in charge of the specialized OPD clinic for diabetic retinopathy in Juntendo University. And today I would like to talk briefly about the key points of diabetic retinopathy that medical students or young doctors from other departments who are not ophthalmologists should know. So let me start by explaining about fundus photography, which will be mentioned many times in today's lecture. And this diagram shows the anatomy of the eye. The reason why we see things so clearly is because everything.
Excuse me.
Yeah.
I'm sorry for interrupt. Can you set in the slideshow?
Yeah. I'm doing the slideshow. Yeah.
Okay, thank you.
Is it okay?
Not
slideshow.
yet. Would you please to click the slideshow icon in the part below, the below part of
slide show here. Is it okay? It's my slideshow.
Okay, you can continue.
I'm sorry. My name is Eijiro. I think you use second display, right? If you use the second one, then I think
second one.
2つディスプレイ使ってないですか？
いや、使ってないです。
そうなんですね。なんか1個、多分スライドショーになってない。
あ、そうですか。どうしよう。どうすればいいかな。
もう一回やってみてもらってもいいか。
もう一回いいですかね。これですよね。で、ここから F5 でスライドショーなんですよね。
その最初からとかでスライドショーとかにした方がいいかもしれないです。スライドショーに多分なってないですよね。
おかしいね。どうしよう。
I'm sorry. It's okay. You can continue with
これは is this better?
Well, you can continue. It's okay.
I think so. Sorry.
Which is better? May I use this one? For me, this is better. Is it okay?
Okay. Wait for a minute, maybe. It doesn't change. It is okay, Dr. Hiratsuka. You can continue from this. I think it's okay.
Yes, okay. So please let me continue my presentation.
Yeah,
okay, so we can see clearly because the cornea is clear. The anterior chamber is not cloudy like in uveitis. and the lens is not cloudy like in cataract, and the vitreous body is not cloudy like in vitreous hemorrhage. And beyond that is the retina. And the retina contains millions of light-sensitive cells such as rods and cones and other nerve cells that receive and organize visual information. And our retina sends this information to our brain through our optic nerve, enabling us to see. And the photograph of the retina is called fundus photography. Okay. And here is the actual fundus photograph showing the normal fundus. And the white circular area near the center is the optic nerve, which is responsible for transmitting the information from the retina to brain. And there are two types of blood vessels, the narrower ones. The narrower ones are arterioles, and thicker ones are veins. Thicker ones are veins. And the ratio of thickness is roughly 2 to 3. And the macula is located in the center of the retina, and this is where we see things. And the macula is the most important part of retina because it is responsible for distinguish fine objects and colors. And in order to have 20/20 vision, the macula must be healthy. Okay. In other words, if the macula is not affected, vision loss will not be noticeable. And in diabetic retinopathy, this characteristic is quite important. Okay. So let me start talking about diabetic retinopathy. And diabetes can damage the heart, kidney, and blood vessels. And it damages small blood vessels in the eye as well. And diabetic retinopathy is a diabetic complication that affects eyes. And it's caused by damage to the blood vessels of the retina. Okay. And what are the risk factors for diabetic retinopathy? The primary risk factors for development and progression of retinopathy are duration of diabetes and level of glycemic control. And as for the duration of diabetes, duration of more than 5 years is a higher risk of developing retinopathy. And as for glycemic control, a 1% decrease in hemoglobin A1C reduces the incidence and progression of retinopathy by approximately 35 and 15 to 25% respectively. And another thing you should know is that hypertension is an additional risk factor. And the American Diabetes Association recommends treating to systolic and diastolic blood pressure of less than 140 and 90 millimeter of mercury, respectively. So if you have diabetes, duration of disease and level of glycemic control are strongly predictive of the development and severity of retinopathy, and controlling these risk factors is important for the prevention of retinopathy. And most importantly, it is basically a preventable disease in the first place. Okay, this is very important. And I believe that there are 3 important characteristics about diabetic retinopathy that medical students and young doctors should know. The first one is diabetic retinopathy affects both eyes, not one eye. Okay. And second one is retinopathy causes no symptoms in the early stages. This is why patients are unable to notice the deterioration of their eye conditions. And the third one is 90% of vision loss from diabetes can be prevented. In other words, if an ophthalmologist sees the patient at the right time, blindness is unlikely to occur. So I will explain each of these 3 one by one. Okay, first one is diabetic retinopathy affects both eyes, not one eye. Some eye diseases are unilateral and some are bilateral, okay? And vision impairment due to systemic diseases such as hypertension or diabetes appears in both eyes, of course. And it can lead to blindness in both eyes. This difference is very important because blindness in one eye is completely different from blindness in both eyes in terms of quality of life. And this point is that the point is that diabetic retinopathy is really a disease that can lead to blindness in both eyes. And this figure shows the distribution of causative diseases in each age group of the visually impaired in Japan. The horizontal axis shows age, and the vertical axis shows the percentage of each age group. And as you can see that the glaucoma, blue bars indicate the glaucoma, and gray indicates the retinitis pigmentosa, and yellow indicates the macular degeneration, and the red indicates the diabetes retinopathy. Okay, and glaucoma and age-related macular degeneration increasing with age. Okay, while retinitis pigmentosa tend to be more common in younger people. But diabetic retinopathy is characterized by its prevalence in working age population. In addition, it can cause blindness in both eyes. Therefore, diabetic retinopathy is a very serious disease. The second one is diabetic retinopathy causes no symptoms in the early stages. What do I mean by this? For this reason, we need to talk about the stages of diabetic retinopathy. There are several different classifications of diabetic retinopathy, but for the purpose of this lecture, we will use the international classification. And in diabetic patients, eyes progress from having no retinopathy through a spectrum of retinopathy severity that includes mild, moderate, and severe non-proliferative and subsequently vision-threatening proliferative retinopathy. And correct identification of the retinopathy severity level of an eye allows a prediction of risk of retinopathy progression, visual loss, and determination of appropriate treatment recommendations, including follow-up interval. So let me show you a typical picture of each stage of diabetic retinopathy. This Fundus photograph showing mild non-proliferative diabetic retinopathy with microaneurysm, which are a small widening of the capillary walls. These are the microaneurysm capillary walls, and they appear as a small round red spots. Okay. And this photograph showing moderate non-proliferative retinopathy with hemorrhages, hard exudates, which are deposition of lipid leaking from the hyperpermeable or vessels and microaneurysms.
Excuse me, Dr. Hiratsuka.
Yes.
Would you please change the presentation, the slide?
Is it changing?
Go down.
Is it changing?
Not yet. Not yet.
Yeah.
Not yet.
Not yet?
Not yet. It is still in the second slide.
Still the second slide? Really? You cannot see my pictures?
Maybe you can drop first the share screen and then share again.
Just a moment. What should I do?
スライドの2番目のしか見えない。ね。次が動いてないんだな。
あ、そうですか。困りましたね。そうしたら、excuse me, so I think the next speaker should do first, and could you share my slide in your from Indonesia? Can you share my slide, which I have already?
Yes. Yes. Okay. Wait for a moment.
Can you share my slide, which I've already submitted?
Yes, doctor, in process. Maybe you can continue with the latest slide.
Can you see international classification?
Oh
No?
yes, it's good. International classification of diabetic retinopathy.
Oh, can you see that?
Yes, sudah. Thank you, Dr.
Can you see next one?
Yes, mild non-proliferative diabetic retinopathy.
Okay. So let me start from here.
Okay, thank you.
Is that okay?
Doctor. Yes.
So this fundus photograph showing the mild non-proliferative retinopathy with microaneurysm, which are small and widening of capillary walls, and they appear as a small and round red spots. Can you see the next one? Can you moderate?
Yes, we can. Moderate non-proliferative.
Okay, so this photograph showing the moderate non-proliferative retinopathy with hemorrhages, headache states, which are deposition of lipid leaking from hyperpermeable vessel as microaneurysm. And this photograph showing the severe non-proliferative diabetic retinopathy, and you can see that more hemorrhagic spots are appearing on the retina. Still, you can see that. Okay.
Yes.
And finally, here's a fundus photograph showing high risk of proliferative diabetic retinopathy with the preretinal hemorrhage and new vessel on the disc. And in this order, the diabetic retinopathy gets worse and worse, and the situation of retinopathy is completely different depending on the stage. And in the early stages, the retinopathy requires observation, and in the severe stage, treatment is necessary. But in the proliferative stage, it can lead to blindness. So let me go back to the second one, which is the retinopathy causes no symptom in the early stages. Why is that? As I have mentioned before, the macula is the most important part of the eye, and we see things in the macula of the retina. In other words, if the macula is not damaged, the vision will not decrease. So let me continue to show and explain the fundus photograph. Oh, please take a look at this picture. And this is a hard X dates. which is deposit of the lipid that leaked from the blood vessels. And there is also bleeding. This level is the stage of the mild retinopathy. But you can see that the macula is normal. Therefore, her visual acuity is 20/20, and she is unaware of the presence of retinopathy. And already firmly, she has retinopathy, but she doesn't realize it. Okay. Next is a retinopathy at the moderate to severe level. And this time, unlike the last time, there are soft exudates scattered throughout the retina. And this is called cotton wool spots. And it indicates acute occlusion of retinal capillaries and edema of the optic nerve fiber layer. And there is also a lot of scattered bleeding. However, you can see that the macula is normal. Okay, so his visual acuity is 20/20, and he's unaware of the presence of retinopathy, even though the retinopathy has progressed to such an extent, he is not unaware of it. And this time, there was a wired thin vessel in the optic nerve papillary, optic nerve papilla that had never been there before. Okay, here. And these are new vessels in the retina. In other words, it is a proliferative retinopathy. And there is also a scattered bleeding and hard and soft exudate, and that can also be seen. But again, please look at the macula. No major damage is seen. The visual acuity is 20/20, and the patient is unaware of the presence of retinopathy. Even though the retinopathy has already progressed to the proliferative stage, which is the final stage, he's not aware of it, okay? And suddenly, these new vessels in the retina are very fragile and can quickly break down, causing major bleeding into the vitreous. And this is when the hemorrhage finally appears in front of the macula, causing vision loss. And patients visit ophthalmologist because they suddenly lose their vision. However, it is often difficult to restore the vision to its original level, even if the patient visits an ophthalmologist in this condition. This is the dreadfulness of diabetic retinopathy. In the early stages of retinopathy, there are no symptoms because they cannot notice it, and it is naturally discovered too late. Eventually, this leads to blindness in both eyes. Okay. And this picture shows the patient I recently saw who had untreated retinopathy and was visiting the ophthalmologist for the first time. Proliferative membrane and neovascularization have already appeared, and the level is at the proliferative stage, which is the final stage. And there are still many patients like this in Tokyo today. So what measures do we need to take? It is a regular screening. This is a scene where fundus photography is being taken, and fundus photograph can be easily taken using camera like this one. So how often should screening be done? The schedule varies greatly depending on the stage of retinopathy. One thing keep in mind is that for mild cases, an annual schedule is fine. And naturally, as the stage of retinopathy progresses, the follow-up interval will become shorter. In this way, the situation of each stage of diabetic retinopathy is completely different. Therefore, when you become a doctor in the future, please be sure to instruct diabetic patients in this way. When you come in contact with diabetic patient, persistently advise him or her to do this. Diabetic eye disease do not show any symptom in the early stages, so you cannot notice them on your own. So please make sure to have a fundus examination at least once a year. Please don't forget to do so, okay? And I will give you another practical knowledge. Many diabetic patients are sloppy. If you tell them to exercise, they won't. And if you tell them not to eat sweets, they will still eat them. And even if you make an appointment for their next OPD visit, they will stop coming. In a year, in Japan, about 8% of diabetic patients stop seeing doctor in Japan. And this is considered to be a very important issue in diabetes management in Japan. And reasons for interruptions in medical visits include business, lack of understanding of the retinopathy, and financial burden. And here are some of the risk factors that make diabetic patients more likely to stop seeing their doctors. Okay, this is a result from a study of 3,600 diabetic patients visiting general clinics in Chiba Prefecture. It's a neighbor of Tokyo, Japan. And this slide shows the factor associated with the continued ophthalmic visits in diabetic patients. Therefore, tuning this result upside down is a risk factor. To sum up, the young male with type 2 diabetes shortly after diagnosis is a risk factor. So these people are more likely to interrupt their medical visit. This result also matches our clinical sense. Okay. Therefore, you should be especially persistent in teaching this type of person over and over again. Okay, risk factor is young males with type 2 diabetes shortly after diagnosis. Okay, this kind of person. And last one is about 90% of vision loss from diabetes can be prevented. In other words, if the patient see an ophthalmologist early and don't interrupt their visit, their treatment will be very successful. The most standard treatment for diabetic retinopathy is laser photocoagulation. And laser photocoagulation is an intervention in which light energy is applied to the retina with the aim of stopping the growth and development of new blood vessels, and thereby preserving vision. And laser treatment is initially proposed as a treatment that might prevent the occurrence of proliferative diabetic retinopathy. And diabetes can also specifically affect the macula, which is called diabetic macular edema. And diabetic macular edema is an important cause of visual impairment caused by diabetic retinopathy, and the leading cause of vision loss among working age individuals. And diabetic macular edema is a swelling in the most important part of the eye, as you already know, the macula. Okay, the vascular permeability of the retina increases, fluid leaks from the blood vessels, and the macula becomes swollen. And this is finding from an optical coherence tomography test, which is CT of the eye, CT of the retina. The normal thickness of the macula, is about 200 micrometer. And the center of the macula is hollowed out like this. And in diabetic macular edema, macula is swollen like this, and the thickness is over 600 micrometer. It's 3 times thicker in this case. Okay. And currently, the most common treatment for this macular edema is anti-VEGF therapy. And this is because a substance in the body called vascular endothelial growth factor, VEGF in short, is involved in the growth of new blood vessels and the worsening of macular edema in diabetic patients. However, the problem with this treatment is that it requires injections into the eye. It hurts, right? And it is the VEGF drug is very expensive. And this table shows the cause of visual impairment in Japan from 1988 to 2015, showing change over time. Diabetic retinopathy was the leading cause of visual impairment in 1988, but has gradually declined in rank and is now the third leading cause of visual impairment after glaucoma and retinitis pigmentosa. As I mentioned at the beginning, it is a preventable disease. And with advances in treatment and patient education, the overall trend is that visual impairment caused by diabetic retinopathy is decreasing in Japan. Okay. And this is the last slide. 3 important characteristics of diabetic retinopathy should be emphasized again. First one is diabetic retinopathy is an important disease because it causes blindness in both eyes in the working age group. And second one is regular screening is very important because there are no symptoms in the early stages. And the last one is, since treatment is very effective, it is extremely very important to see an ophthalmologist as early as possible and not to interrupt the visit. Oh, well, that's all from me today. Thank you very much for your listening.
Thank you, Dr. Hiratsuka, for complete explanation of diabetic retinopathy. Okay, students and lecturers, this is interesting that 90% of vision loss from diabetes can be prevented. Yeah, we have learned about diabetic retinopathy, then primary risk, characteristic of diabetic retinopathy, then affect both eyes, distribution of causative disease, and so on. So we are in Q&A session. Here is the question for this session. Dr. Hiratsuka, this is question from Ocean. This is our student, but his name is
Ocean. Ocean, thank you.
Okay,
thank you very much for your question. Which is better between laser treatment, retinal surgery, and VEGF for retinopathy? Okay. For diabetic retinopathy, usually the laser treatment is the first line treatment. Okay, it's a standard one. And if it doesn't work, we need to do surgery. And VEGF therapy is good for the diabetic macular edema. For diabetic macular edema, compared to laser treatment, the VEGF therapy is more effective. Okay, that's my standard question, standard answer. Is it okay, Ocean?
Okay, I think it's a clear answer. And the second one is from Laila Chahya. Is there any method for predicting the severeness of diabetic retinopathy except fundus images?
Predicting severeness, it's a glycemic control. Basically, the level of hemoglobin A1C is the most important predicting factor of the severeness of diabetic retinopathy. Okay. General condition is more important. And of course, the fundus image is very important. But the level of blood sugar control is more important. Is it okay?
Okay,
Yeah.
Dr. Hiratsuka. So we had 2 questions from this Q&A session, and the 3 questions more, we will deliver it in the comprehensive discussion.
Okay.
Okay, Dr. Hiratsuka, this is the end.
I'm very sorry about the trouble of my slide presentation. I'm very sorry about that.
Okay, but we have solved it, so it's okay. Thank you in advance. Okay, students and lecturers, we move to the 4th speaker session. Allow me to read the curriculum vitae of the 4th speaker. Associate Professor Dr. Keiichiro Matoba, M.D. Ph.D. Slide. He was born in Tokyo, Japan. He works in Division of Diabetes, Endocrinology and Metabolism, Department of Internal Medicine, the GK University School of Medicine. He got medical degree in 2003 from the GK University School of Medicine, Tokyo, Japan. In 2013, he got Ph.D. degree from the GK University School of Medicine, Tokyo, Japan, in field of endocrinology. Awards: Dr. Matoba got Research Award in 2014 from the GK University School of Medicine. In 2019, he got Medical Research Encouragement Prize of the Tokyo Medical Association and Medical Research Encouragement Prize of the Japan Medical Association. And then in 2002, he got Banyu Research Award, M.Sc Life Science Foundation. And the research funding, Dr. Matoba gets research grant from Suzuki Memorial Foundation and Takeda Science Foundation in 2019, Boehringer and Lilly Diabetes Research Grant, Japan Diabetes Foundation grants in aid for scientific research, Japan Society for the Promotion of Science in 2020. Dr. Matoba here had certification as diabetes educator of the Japan Diabetes Society in 2020, board certified endocrinologist of the Japan Endocrine Society, and certified endocrine educator of the Japan Endocrine Society. And the publication of Dr. Matoba are international publication in diabetes. That's the curriculum vitae of Dr. Matoba. Are you ready to present your PPT, Dr. Matoba?
Yes, thank you for your presentation. Let me share my slides with you. Okay. Is this working?
Started screen sharing. We are waiting for the PPT.
My slides? No.
Maybe it takes a little time.
Okay.
Dr. Matoba, do you need help from the committee?
Can you see my slides now?
Yes. It's good. Okay, slideshow, please. That's clear. Okay, thank you.
Thank you.
John.
Okay. Hello, everyone. Welcome to my presentation. My name is Keiichiro Matoba. I'm an endocrinologist at GK University School of Medicine, Tokyo, Japan. So my topic is diabetic nephropathy. I'd like to talk about diagnosis and the management of diabetic nephropathy. So if you break the term diabetic nephropathy into diabetic and nephropathy, literally means kidney disease that occurred secondary to diabetes. Diabetic nephropathy is very important because this is the #1 cause of renal failure all over the world, and this is a high-risk condition for cardiovascular disease and death. So controlling and managing and diagnosis early is important to prevent the progression and the death in patients with diabetes, regardless of diabetes type 1, type 2. So here is my table of contents. First, I will talk about epidemiology of diabetes and diabetic nephropathy. Then I will look at some pathophysiology of diabetic nephropathy and how to detect diabetic nephropathy. And finally, I will talk about interventions for diabetic nephropathy. So let's start with epidemiology of diabetes and diabetic nephropathy. This slide shows diabetes around the world in 2021. International Diabetes Federation reports a continued global increase in diabetes prevalence, as Dr. Wynn reported first. Now, 500 people are living with diabetes, and this is predicted to rise to 800 million in 2045, especially in the low and middle income countries like Africa, Middle East and North Africa, Southeast Asia, and the Western Pacific. So diabetic nephropathy is far more common in people with diabetes than in people without diabetes. Nephropathy affects about 20 to 40% of all individuals with diabetes. The prevalence of end-stage renal disease, in short, ESRD, which means a renal failure or chronic diuresis, is up to 10 times higher in people with diabetes. So since 1968, the Japanese Society for Dialysis Therapy has conducted a survey of chronic dialysis treatment at the end of every year. This slide shows the number of patients undergoing dialysis in Japan. As you can see here, the number is increasing annually. However, the rate of increase has slowed in recent years. This is probably due to the advancement of management of chronic kidney disease, not only diabetic nephropathy, but hypertensive nephropathy or glomerulonephritis. So this slide shows trends in major primary cause of diuresis in Japan. The most common primary cause among diuresis is diabetes at almost 40%. As you can see here, it's a brown line. This is diabetes. And followed by chronic glomerulonephritis at almost 30%. And nephrosclerosis, which means atherosclerotic change induced by hypertension, is increasing practice. It's about 10%. This is probably due to the population aging. So why the management of nephropathy is important in patients with diabetes? As you can see here, the presence of nephropathy markedly increases cardiovascular risk and death and healthcare costs. From diagnosis of diabetes, progression from non-nephropathy to microalbuminuria occurred at 2% per year, and microalbuminuria to macroalbuminuria at 2.8%, and macroalbuminuria and to elevated plasma creatinine for renal replacement therapy, which means renal failure, at 2.3%. However, the annual rate of death is 1.4, 3, 4.6, and almost 20% if patient is renal failure stage. So the death rate exceeds the rate of progression towards nephropathy. So please make sure that the patient with diabetic nephropathy is the high-risk condition of cardiovascular death. So let's move on to the next topic, physiology of diabetic nephropathy. This is a slide showing normal venous handling of albumin, which is shown in green spheres, as shown here. Albumin normally remains within the capillaries like this and does not escape into the urine, which is called Bowman's space. So to limit the albumin loss, the glomerular filtration system is very important. Glomerular filtration barrier comprises of the innermost endothelial cells, as shown here, and glomerular basement membrane, and podocytes photoprocesses, which is also called as glomerular epithelial cells. This is a kind of like a coffee filter to limit the albumin in the capillary space. And proximal tubule is also associated with albumin dynamics. Albumin is reabsorbed by megarin and a cubrine receptor, which lining at the brush border of proximal tubular cells. So this is a normal system. So what will happen in the setting of diabetes? So this is a characteristic glomerular change of diabetic nephropathy. Panel A is normal glomerulus. You can see mesangial cells in Bowman space, endothelial cells, glomerular basement membrane, as well as both sides. This is normal glomerulus. However, in diabetes, you can see glomerular basement membrane thickening, as shown in green line, and podocyte loss, which leads to proteinuria, and increased mesangial extracellular matrix in the mesangial cell hypertrophy, which is also called as mesangial expansion. This leads to the reduction of glomerular filtration surface area, and eventually the loss of glomerular filtration rate. This is a light microscopic and electron microscopic images of diabetic nephropathy. The hallmark is a localized increase in extracellular matrix, and which is called as Kimmel-Steele-Wilson nodule. Kimmel-Steele-Wilson nodule is this and this. And you can also see mesangiolusis and arteriohydrinosis. Electron microscopic image also shows that, microaneurysm filled with erythrocytes and food process effacement, which is the podocyte damage, and the GBM thickening, as we discussed before. So how do we detect diabetic nephropathy? It's important to diagnose diabetic nephropathy before glomerulosclerosis, as I showed in previous slide. So this slide shows natural history of diabetic nephropathy. Nephropathy is usually clinically diagnosed by the presence of albuminuria, which means elevated levels of urinary albumin and low eGFR, estimated glomerular filtration rate. So this is a natural history of glomerular filtration rate and a proteinuria. So at the initial stage, sometimes patient shows hyperfiltration. If you do biopsy, we do not biopsy at this stage usually, but histologically you will find kidney hypertrophy at this stage. And in the microalbuminuria stage, proteinuria will gradually increase like this. And histologically, mesangial matrix expansion, glomerular basement membrane thickening, arteriohydrinosis are the hallmark of diabetic change in the kidney. After this, glomerular filtration rate will gradually decreases and proteinuria increases. And in this stage, you will see overt proteinuria. And if we do biopsy, we can find mesangial nodules, which is called as Kimmel-Steele-Wilson, as well as tubular interstitial fibrosis. So when you diagnose diabetic nephropathy with measure albumin to creatinine ratio by patient's urine. ACR means albumin to creatinine ratio, and normal range is defined as under 30 milligram per gram creatinine. So this is normal level. And if you see albumin levels between 30 to 300 milligram per gram creatinine, that means microalbumin stage. And if the patient has over 30 milligram per gram creatinine, that means macroalbuminuria stage. Because of high biological variability between measurements in ACR, 2 of 3 specimens of ACR should be abnormal before considering a patient to have albuminuria. And exercise and infection, fever may elevate albumin to creatinine ratio independently of kidney damage. So please make sure the patient does not have such conditions. And if patient has such conditions, please avoid evaluation of the stage of nephropathy. This is the prognosis of nephropathy by GFR and albuminuria categories. Green area is low risk
Caranya gedein suaranya ya.
and red area is high risk. The degree of albuminuria, A3 is a severe condition than A1. This is associated with the risk of end-stage renal disease and also cardiovascular disease and mortality. So at least annually, ACR and eGFR should be assessed in patients with diabetes. ADA recommends to examine ACR at least once a year. However, if you see these findings in patients with diabetes, please refer to nephrologists because the typical presentation of nephropathy is considered to include a long-standing duration of diabetes. And retinopathy, retinopathy means that the patient has long duration of diabetes. So if you see active urinary sediment like red blood cells or white blood cells in urine, and when you see rapidly increasing albuminuria or nephrotic syndrome, rapidly decreasing eGFR, or absence of retinopathy in type 1 diabetes, please refer to a nephrologist for the further diagnosis, including the possibility of kidney biopsy. We do not do biopsy in patients with diabetes to diagnose chronic kidney disease, but if you see these findings, we should rule out other disease, other glomerular disease. So finally, I will explain about interventions for diabetic nephropathy. This is the STENO2 study, which was conducted in Denmark to examine the effect of multifactorial interventions for patients with diabetes, type 2 diabetes. As you can see here, this panel shows CVD events in intensive therapy, which is shown in green line, and a conventional therapy. You can see CVD events is lower in intensive therapy group compared to conventional therapy. The macrovascular events, including nephropathy, retinopathy, and autonomic neuropathy, are decreased by multifactorial interventions. Multifactorial means interventions for hypertension and hyperglycemia and dyslipidemia and smoking, something like that. So please make sure to do intervention not only for hyperglycemia, but please do a multifactorial intervention if you see a patient with diabetic nephropathy. This study was conducted in Japan to see the impact of type 2 multifactorial interventions in type 2 diabetes. Interventions for high glucose, hypertension, and dyslipidemia reduce cardiovascular events, as shown here, and prevented nephropathy. So when patient has multiple factors like diabetes, hypertension, or dyslipidemia, do not treat one factor only. Multifactorial intervention is important to prevent diabetic nephropathy and cardiovascular disease. So how should we do interventions for patients with diabetes? For all patients, glycemic control, blood pressure control, lipid management, exercise, nutrition management, of course, smoking stopping are required. And for most of patients, SGLT2 inhibitors last blockade would be beneficial. I will talk to you later. And for some patients, like for patients who suffered cardiovascular disease once, antiplatelet therapies like aspirin is recommended to prevent second attack. So regarding the nutrition, this slide shows the effect of decreased sodium intake on various outcomes. Restriction of dietary sodium is very useful to control blood pressure and reduce cardiovascular disease risk, like myocardial infarction, angina, or stroke. So, and when we manage hypertension in patients with type 2 diabetes, we should understand the renin-angiotensin system. The renin-angiotensin system is activated in renal tissue of diabetes. Angiotensinogen is converted by renin to angiotensin 1, and the angiotensin 1 is converted by angiotensin converting enzyme to angiotensin 2, which binds to angiotensin 2 receptors. And angio-AC inhibitors inhibit this, and angiotensin 2 receptor blockers, in short, ARB, blocks this. So hypertension is a strong risk factor for the development and the progression of nephropathy. And the renin-angiotensin system is activated in the renal tissue. And this study was conducted in order to investigate the effect of ARB. So as you can see here, compared to placebo, change in the levels of proteinuria is low in losartan treated group. Losartan is a ARB. And if you look at the percentage of end-stage renal disease, this is lower in losartan treated group compared to placebo treated group. So really it's recommended to use ACE inhibitors or ARBs in the management of type 2 diabetes and hypertension. However, combined RAS inhibition is associated with adverse events. I mean, the combination use of ACE inhibitors and ARBs should be avoided because, as this study shows, acute kidney injuries is higher in losartan plus lisinopril treated group. Losartan is a ARB and lisinopril is a ACE inhibitor. So compared to losartan only group, acute kidney injury is higher in losartan plus lisinopril group as shown here. And hyperkalemia is also higher in ARB plus ACE inhibitor treated group compared to ARB only group. So there is no benefit of combination of ACE inhibitors and ARBs. So please use ACE inhibitors only or ARB only or combination with other agents like calcium channel inhibitors and diuretics. So now lots of large-scale clinical trials are ongoing regarding SGLT2 inhibitors. SGLT2 inhibitors has been shown to reduce the risk of nephropathy progression as shown here. Declare TIMI 58 canvas empirical outcome, credence, a large clinical trial to examine the safety of SGLT2 inhibitors in patients with type 2 diabetes. And it has been shown that renal outcomes, including doubling of serum creatinine, initiation of renal replacement therapy, or renal death, were lower in SGLT2 inhibitor treated group compared to placebo. So why SGLT2 inhibitors are effective for the management of diabetic nephropathy? Diabetes is associated with afferent arteriolar dilatation, as shown here, and this is eventually leads to intraglomerular hypertension. However, if we use SGLT2 inhibitors for patients, we can expect afferent arterial constriction and downregulation of glomerular hypertension, and which eventually leads to reduction of proteinuria. So this is a suggested mechanism of SGLT2 inhibitors on the kidney. SGLT2 inhibitors also has been shown to reduce cardiovascular risk in patients with type 2 diabetes. Interestingly, cardiorenal benefits were still seen down to eGFR levels of 30 milliliters per minute of eGFR. So, as the clinical trials, including DECLARE-TIMI, CANVAS, empirical outcome, and credence, are cardiovascular outcome, especially heart failure, was inhibited in SGLT2 inhibitors treated group. So as I told you in the previous slides, diabetic nephropathy is a high-risk condition for cardiovascular disease. So this is important data to use these SGLT2 inhibitors for patients with type 2 diabetes. And some direct effects, not only for glucose management, but direct effects on cardiovascular system is suggested, like for left ventricular hypertrophy, and for elevated cytokine and inflammation, and for extracellular matrix remodeling, impaired cardiac metabolism, and cardiomyocyte apoptosis. So these are potential pathways associated with SGLT2 inhibitors. SGLT2 inhibitors ameliorate a variety of cardiovascular risk factors like high glucose conditions and dyslipidemia, oxidative stress, adiposity. Obesity and adiposity is very important mechanism for not only for nephropathy but also for cardiovascular disease. So SGLT2 inhibitors are very important technical options for a patient with obesity and insulin resistance. We can also expect down-regulation of sympathetic activation for hypertension and arrhythmia. So compared to sulfonylurea, which was clinically used as a main agent for type 2 diabetes for many years ago, glimepiride is a sulfonylurea, and as you can see here, body weight is increased by the treatment with glimepiride. But in the empagliflozin, which is a SGLT2 inhibitors, in this group, body weight is decreased. So this is a a big difference. So sulfonyl urea increases body weight, but SGLT inhibitors not. So when we manage, when I see the patient with type 2 diabetes and obesity and diabetic nephropathy, this is important data. And we have another option, GLP-1 receptor agonist. This reduces appetite and gastrointestinal motility. We can expect appetite downregulation and moving of gastric emptying, which eventually leads to body weight loss. GLP-1 receptor agonist has multiple functions, not only for appetite. It has been shown to be effective for renal, for diabetic nephropathy, and the pancreas function, and the heart. So this is a mechanism of renal protection of GLP-1 receptor agonist. GLP-1 receptor agonists is effective for body weight control and renal tissue inflammation and atherosclerotic changes in the kidney. And also we can expect the vasodilation, which leads to inhibition of glomerular hypertension and the renal protection. So, okay. So that brings me to the end of my presentation. We looked at 4 main points. First, I showed you that diabetic nephropathy is the high-risk condition for cardiovascular disease. So don't forget the risk of cardiovascular disease when you see patients with nephropathy. And then obesity and insulin resistance are important mechanisms for the progression of diabetic nephropathy. And multifactorial intervention, which means the treatment for glucose, hypertension, and dyslipidemia is recommended. And when we manage the hypertension and hyperglycemia in patients with type 2 diabetes, LAS inhibition and SGLT inhibition are very useful and has been proven to be beneficial, not only for the kidney, but also for the heart. Okay, thank you very much for your attention. Terima kasih. If you have any questions or comments, I'm happy to answer them. Thank you.
Thank you, Dr. Matoba, for the crystal clear explanation of diabetic nephropathy. Students and lecturers, it's interesting that there is clinical trials ongoing on SGLT2 inhibitors to reduce risk of nephropathy progression and Sp.PD in type 2 diabetic patients, and it also can reduce body weight, right?
Right.
Okay. This is the Q&A session. We have Shiva Ramadhani Susilo. Please, on mic, you can ask by yourself to Dr. Matoba. Shiva?
Questions from Shiva?
Yes, please.
Yeah.
Hello?
Yes, I want to ask about relation between level urea creatinine or kidney function and grading chronic kidney disease.
Okay, thanks for your question. So you're asking about the relation between serum creatinine levels and or kidney function and grading CKD. So the classification of CKD and the diabetic nephropathy is probably different in depending on the countries. And in our countries, diabetic nephropathy is included in the chronic kidney disease, and we diagnose diabetic nephropathy by measuring urinary albumin levels and serum creatinine. And in the laboratory, we visually measure estimated glomerular filtration rate, which is calculated from serum creatinine. And but we can refer the CKD grading from International Kidney Society. Probably that was the Keiichiro, which is called Keiichiro. Keiichiro announces the grading about CKD. So if you want to know the international classification, you can refer to the Keiichiro guideline. Thank you.
Okay, thank you. Shifa, is that clear? Okay, I think it's pretty clear. Dr. Mahmuda. Yes. The next question comes from Edwin Henry Kurniawan. Could you please to on your mic?
Okay, from
Hello, doctor. I want to ask about relation between hemodialysis and chronic kidney disease that causes diabetic nephropathy. Yes, thank you.
Okay, thank you for your question. You were asking about the relation between hemodialysis and the CKD and diabetic nephropathy. So as I showed in the slides, the number of patients undergoing hemodialysis is increasing, and the number one cause of hemodialysis is diabetic nephropathy. And this trend will be same in your country and other countries. So yes. Is this clear for you?
Yes, so number one cause of hemodialysis is diabetic nephropathy. So it's very important to us to maintain the diabetic, right? Okay, I think it's enough. Edwin and Shifa, thank you for the discussion with Dr. Matoba. Dr. Matoba, this is the end of fourth speaker session. Thank you in advance.
Thank you.
Okay, students and lecturers, we are now in the comprehensive discussion for 20 minutes ahead. We have questions that will be answered by the speakers, Dr. Iin, Dr. Yamada, Dr. Hiratsuka, and Dr. Matoba. Well, we can start the session. Allow me to read the question in this session. Okay, from Halika Irza Ramadanti to Dr. Novita. Which organ in the earliest to experience complications of type 2 diabetes mellitus, and the last one, and why? Please, Dr. In, and later we ask for another speakers.
Okay, may I answer now?
Yes.
Okay. Actually, many research had found that both macrovascular and microvascular develop simultaneously in diabetic patients. There are three phases of pathomechanism on type 2 diabetic before one patient is diagnosed by diabetes. The first phase is impaired glucose tolerance. In this phase, the macrovascular complications have been running actually. Then when the second phase is undiagnosed diabetes, which is the blood glucose actually have been above the normal limit, but the patient have not known yet. This is start the microvascular complication. So it's happened simultaneously in diabetic patients. On the other hand, there are many reports like patient with diabetic type 1 with early and aggressive coronary artery disease without evidence of nephropathy, neuropathy, and retinopathy. So this process start maybe 5 until 10 years before someone is diagnosed for diabetes. So it has been started when beta cell pancreas function is decreased, your blood sugar actually between normal and pre-diabetic state. So if one patient is diagnosed for diabetic, doctor should also start the screening for all complications, micro and micro complications. That is my answers.
Thank you, Dr. Iin. Is there any additional answer for this question? Dr. Yamada, maybe?
Oh, thank you for your answer questions. I think the around the microvascular complications, I think it has been reported that the neuropathy is the first, and then the retinopathy, and finally the nephropathy has happened. But recently, if you use the microalbumin, urine albumin ratio, and it happened earlier than the one before we believed. So maybe the neuropathy and the nephropathy is first, and then the retinopathy is after 5 years. The blood sugar level is higher, like that, I guess. Thank you very much.
Thank you, Dr. Yamada. Dr. Hiratsuka, is there any additional answer?
Yes, as Dr. Yamada mentioned that it takes time to develop the retinopathy in diabetic patients. At least maybe 5 years, sometimes 10 years, it takes time to develop retinopathy. So retinopathy is, I think, is developed in the later stages, I think.
Okay,
that's my additional comment. Thank you. Yeah.
Dr. Matoba, is there any additional answer?
Yes, as Dr. Yamada mentioned, I also believe the neuropathy is the first. And nephropathy is not the earlier one. Because as in my presentation, I explained we refer to nephrosis if a patient has nephropathy, but patient does not have retinopathy. So in general, neuropathy first and nephropathy later. But it depends on the risk factors, I think. If the patient has super high glucose levels, it's associated with retinopathy. It has been already reported. And if the patient has severe obese condition, obese state is strongly associated with cardiovascular risk. So it depends. Thank you.
Okay, thank you, speakers. That is our first question for this session. Next question, please. From Naura Salsabila to Dr. Eijiro Yamada. Is there any kind of recommendation diet to lower HbA1c? Is there any kind of treatment to lower them without insulin?
Oh, it's a kind of important question. Thank you very much. I guess the answer is we have no magic diet or magic treatment actually. So the many meta-analysis according to the food, the eating, the behavior, we don't have any evidence that this food is good or not. So maybe the carbohydrate is one of the important factor to lower the hemoglobin A1C. But if you reduce the carbohydrate, then you have to have a fat or protein. That leading cause to the CV event or something like that. So I think the balanced food is the recommendation diet is a balanced food. Not too much carbohydrate, not too much fat, and not too much protein, I think. So maybe if you watch out the carbohydrate, then you can decrease the insulin injection. But I think it's not so important to think about only diabetes. I think we have to have think about more like comprehensively, I think. Thank you very much.
Thank you. Dr. Ian, is there any additional answer?
I think each patient should, I would like to answer the second question. Is there any kind of treatment to lower them without insulin injections? I think each patient should follow their physician's advice, whether to increase the dose of their oral diabetic agent, add on another oral diabetic agent, or start with the insulin therapy. So each patient should discuss with their physicians about their preferences, obstacles. Is there any social or economic burden that avoid them for using this insulin? Because the perfect match for diabetic patient is insulin, actually. Thank you.
Thank you, Dr. Ian. Is there any additional answer from Dr. Hiratsuka?
No, I don't have any additional answer because I'm ophthalmologist. I'm not very specialized to it.
Yeah. Dr. Matoba, is there any additional answer?
Yes, I believe if we selecting diet, vegetables and dietary fiber will be beneficial. But yeah, there is no special magic food, I think. Thank you.
Okay, thank you, Dr. Yamada. Next, for the third question, please. Next, okay. From Eric Krishna to Dr. Yoshimune Hiratsuka. In metabolic syndrome, is it more important to treat the hypertension first or the diabetes? Is there any direct medication besides antihypertension or diabetic drugs? Thank you.
In metabolic syndrome, is it more important to treat hypertension first or diabetes? Is there any direct medication besides antihypertension or diabetic drugs? I'm not sure about the drugs, but both are important. Both are important. As Dr. Matoba mentioned in his presentation, multifactorial intervention is also very important for diabetic retinopathy. And I see patient, their blood control, blood pressure, blood sugar control is not so bad, like hemoglobin A1C is like 7.5 or 7.6, but every time I see the patient, the retina get worse and worse. And when I ask the patient about their blood pressure, the systolic blood pressure is beyond 200 or something. So hypertension is very, very important factor to control the development of retinopathy. And it is said that when we 10% increase of the systolic blood pressure, the rate of progress of the retinopathy is going to be 10% higher. So both hypertension and diabetes prevention are important. I cannot say which is more important. I'm sorry, that's my answer.
Thank you, Dr. Hiratsuka. Dr. Matoba, maybe there is question answer.
I have same opinion with Dr. Hiratsuka. Yeah, both factors are important. So please treat hypertension and diabetes both at the same time.
Okay, thank you. Dr. Ian, is there any addition answer?
Yes, I agree with all the speaker that each of them are important. So hypertension patients should control their blood glucose, and diabeticians also should control their blood pressure. So both of them are the same. They are very important.
Okay, thank you. And Dr. Yamada, is there any?
I agree with everyone. Actually, the many reports support the both of them are very important factor for the metabolic syndrome, complications. Actually, I think for the microvascular or macrovascular, both of them, it's very important to maintain the hypertension and the blood sugar, I think. Thank you.
Okay, thank you, Dr. Yamada. The first question, please. Sally Widiakusuma. For the choice of therapy for gestational diabetes, it's better to take drugs or insulin. Dr. Matoba, maybe?
Okay, for the treatment of gestational diabetes. Okay. Is it better to take drugs or insulin? In Japan, it's not allowed to use anti-diabetic agents, oral agent, for a pregnant person. So we choose insulin when we do management of hyperglycemia for gestational diabetes. But I know in some countries, metformin is available for gestational diabetes, but in Japan, it's not allowed to use.
Okay. Metformin. Okay. Dr. Ian, is there any additional question?
Okay, thank you. There are not many options. There are not many options for gestational diabetic. In Indonesia, metformin is allowed to be given in pregnant woman with or without insulin. So I think if the blood glucose is too high, it's better to use insulin in in the first trimester of pregnancy, so the babies and the mother could maintain their healthy until the delivery. Thank you.
Okay, thank you. Dr. Yamada, is there any additional question? Answer.
Thank you. I don't know the gestational diabetes in Indonesia actually. So in Japan, the gestational diabetes is not diabetes actually. It's before the diabetes, but if you have a little bit higher blood sugar, then they're gonna be diagnosed as gestational diabetes. And if you have a diabetes already, then it's gonna be diagnosed as overt diabetes in pregnancy or something like that. So it depends, I think. So if the gestational diabetes, which means that not so which is not so much higher glucose level, then I think the best way is the diet. So you should have the diet like 6 times a day, not 3 times. So then the blood sugar after the meal is not so increased. So the diet is very important. If you have a diabetes, then you should have an insulin. Actually, some people believe the insulin is not good for the pregnancy or something like that. So the patient doesn't want to have an insulin. That is not so good. So I think that we should have a good we should have a good idea for the treatment for the diabetes in pregnancy, I think. Thank you.
Okay, thank you. Dr. Hiratsuka, is there any additional answer?
No, I don't have any additional answer.
Okay. Okay, this is very exciting discussion, speakers and participants, but we have run out of time to comprehensive discussion. Students and lecturers, that is the end of our plenary session. Thank you, Dr. Iin, Dr. Yamada, Dr. Hiratsuka, Dr. Matoba. As moderator, I'd like to thank you very much for your cooperation. Okay, next session will be guided by Prof. Yashiro. Prof. Yashiro, I give it back to you for closing remarks.
Okay, thank you so much. Can you hear me?
Yes.
Okay,
Yes.
just a moment, please. Okay, thank you, everyone. I would like to say thank you very much for all the people participating in this webinar. This seminar is coming to a successful conclusion. So I thank you, especially for 3 Japanese speakers, lecturers. After COVID-19 is over, please make a chance to visit the Indonesia and to make a direct face-to-face lecture to them and talk to them and interact with them. It's my true hope. So with this very short, brief message, I would like to close this second webinar sponsored by 2 associations, Japan and Indonesia. Thank you very much, everyone. Thank you.
Please, the Master of Ceremony.
Okay. Okay, we have entered our answer sessions. On behalf of the committee members, we apologize if there is a shortcoming in this event. Until we meet again in another occasion, wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much.
Okay, very nice meeting. And I was so much impressed that Indonesian people, Indonesian doctors, very much so active. And also your activities are very much influenced to the Japanese audience as well. So we hope we continue this kind of the activity related to the many other fields. I am a geneticist actually. So diabetes is also based on the genetic background. So I'm interested in this so much about the diabetes in the genetics in diabetes in Indonesia. I think a little bit different background in the diabetes genetics compared to the Japanese. For instance, the Pima Indian, very famous have a higher frequency of the type 2 diabetes, Pima Indian. So this kind of the genetic background is very much important. So this kind of the collaboration may be important to know about this genetic background as well. Okay, thank you very much indeed. Fantastic meeting.
Thank you very much, Prof. Thank you, the speakers.
This kind of activities. Thank you.
The professor and committee, Master of Ceremony, the chairman and the moderator. Thank you.
Okay, thank you.
Recording stopped.